Scientific evidence meet clinical practice. So in the next 20 minutes, I want to talk about how electrical stimulation can support upper limb rehabilitation in cervical spinal cord injury. To start, before we can transfer the treatment to clinics, we have to get knowledge about what we are doing. That means we have to gain a theoretical background. That includes doing research and having a tool for diagnostics. So then by doing research, we regain evidence, and with this evidence, we can transfer into clinics our treatment. Getting a little bit more in detail. So what happens after spinal cord injury in the central nervous system? So the brain is less effective at driving information through residual spinal pathways. That's because the ascending and descending nerve tracts continue to deteriorate. And you see it here on the picture where the spinal cord lesion is signalized with a flash. So our intention is to regain function. That means that we do neuromodulation in the first weeks after spinal cord injury, and the neuromodulators in the treatments are the neural circuits that are usage or use dependent, and they show plasticity. But in other words, if we don't use them or don't get information to them, they lose their capacity. And on the other way around, if we increase the usage, then we can improve the efficiency of these neural circuits. So at least that means that motor control depends on descending supraspinal drive. Now, electrical stimulation comes in the field of action. So how can electrical stimulation be implemented in this system? So it can be used for strengthening these already mentioned functional pathways. It might guide adaptive plasticity, and it can activate damaged networks. And of course, to induce neuroplasticity via cortical controlled electrical stimulation is the main goal in the first time after acute spinal cord injury. We focus now what is going on in the spinal cord, in the central nervous system, but at the same time also in muscles, a cascade starts to take place. And the cascade includes muscle atrophy, a fiber type transformation from type fiber 1 to type fiber 2X. Then in addition, the oxidative and glycotic capacity decreases, the entire metabolic process in the muscle decreases, and at least a muscle can increase connective tissue, so the muscle morphology changes, and at least in addition to muscle atrophy, also the contractile properties are decreased and not functioning anymore like they did before. The benefits of electrical stimulation are, in addition, that changes in paralyzed muscles can be treated and even to a certain degree reversed by the application of electrical stimulation. Some things should be considered by applying electrical stimulation, and that's the stimulation itself, the parameters of the stimulation, and the protocol, how electrical stimulation is conducted, the type of electrical stimulation, so independence of the presence of an upper or motor neuron lesion, or in other words, if I apply nerve or muscle stimulation, then the frequency plays an important role if I use low or high frequency, and not at least the stimulation volume. That means how many times a week or a day do I apply electrical stimulation to regain some function or to fulfill my tasks. And if you look to the slides, the first step is in this order to set up the proper stimulation protocol to decide or to diagnostic the kind of lesion, so upper or lower motor neuron lesion. Afterwards, I look to the target. Do I want to stimulate on a structural base only to change muscle morphology, or do I want to use it as functional training? That means in an action or in a daily life activity. And at least the stimulator choice is critical because it's independence. If I have a lower upper motor neuron lesion, if the stimulator might provide microseconds as pulse width, microseconds and milliseconds, so that I can cover both, or only milliseconds. And if you look now to the data I collected in the last year in the Swiss Paraplegic Center, then you see the percentage, how many patients came for first evaluation with an upper and lower motor neuron lesion or combined lesions, and you see that the lower motor neuron lesion are in favor to the others. This is a quite busy slide, but only look to the colors here. Here you see the type of lesion on the top, and the blue side is the lower motor neuron lesion, the green side is the upper motor neuron lesion, and you see also the different diseases under it written. And in the middle you have some double-colored diagnosis or targets, and those can be served by an upper and lower motor neuron lesion, respectively by the stimulation of an upper and lower motor neuron lesion. And at the end, at the bottom of the slide, you see the belonging parameters in which field you use the correct parameters. So in green you see these short pulses in microseconds, and in blue the long pulses with milliseconds. And at least the pulse duration is responsible for the stimulation if you can serve lower or upper motor neuron lesion. Coming to the next, you see different stimulators, and for me in clinics it's absolutely independent how the name of a stimulator is. It's crucial to know about the usage of the stimulator and if a stimulator can be programmed. And you see a lot of devices here, and on the left lower side you see the RISE stimulator, the worldwide only and unique stimulator you can really use for lower motor neuron lesion, and that is effective to keep muscle structure over years. Another sophisticated device is what is used now newly, that is the multi-pad electrodes you see in the upper row, where you see the big electrode with multiple small electrodes integrated that you can stimulate very selectively, and that's mostly used for hand function. The only but in this story is that it can't be only applied for upper motor neuron lesions. So on the motor learning slide, I don't want to go into in detail. All of us know that motor learning has different stages, and the most important is that we stick to the stages in accordance to the situation of the patient. That means if I want to relearn function, it is not very important in the beginning to know how or the quality of the movement. It's only important that the patient knows about the movement and not about the quality. Only in a later stage it is important to give feedback about the quality. And as long as the patient is trained on a function and get more familiar and get to the autonomous phase, then we can expect that the quality is perfect, independent of speed and environment. Here you see an example of a patient who wanted, after years in a chronic stage of spinal cord injury, to regain finger function in terms of closing his shirt. And he was not able to have this pinch to reach his goal, and we trained this patient over a certain time. And he was, at least by training twice a day, he was able to do after 12 weeks, to close his shirt with a normal function. And interestingly, he could gain his function for long term. He needed not to continue with the stimulation. And I always say it's not a miracle. That is a typical example of learned disuse. And stimulation is able to get the right information to function in nerves and function in structures to regain a function. Another example is this lady who uses a triceps training first, and here you see very clearly the stages of motor learning. You see in the beginning it was only important that she realized the movement, and in further steps we were keen on the quality of movement, that she can use it in a standing frame or even for transfers to push up her own body weight and her trunk. In the next, stimulation is integrated in task for transfer training, and we stimulate the shoulder setting in combination with some shoulder stabilizers. And by doing this, we used a foot switcher that is normally used for foot drop systems, and we put it under the hand. And every time the patient tried to have his body weight on the arm and do transfer activities, his shoulder blade was stimulated. A combination of virtual reality feature and stimulation of the triceps is shown here. This lady tries to play tennis. She was a professional tennis player before, and so she could use her already learned motor tasks for relearning on a muscular base by playing tennis with a Wii station. The next gives an example where we include the motor point mapping to figure out for the best electrode positioning. And so we looked to the pronation of this patient, and we trained it with a weight. So he stimulated daily the pronators, and after a short while, as shown in the video, he was able to pronate the arm without stimulation. That was also a motor learning process. That means 3 weeks later, the patient didn't need to stimulate anymore, and he regained the function. Here are some nice examples with a haptic system, with glasses, where you see some tasks that you can support with electrical stimulation, and that works fine in both, as seen in the left picture with lower motor neuron lesion, as well as seen in the right picture with an upper motor neuron lesion, and you can use switches easily. Another more sophisticated example is motor learning, again, that was regaining function in a triceps, but this patient has in addition a weakness in his trunk muscles, so we put him on the side, and he had to play tennis for strengthening the triceps and only backhand. And at the same time, electrical stimulation was applied to the trunk, and he played it quite successfully, and so he could get more strength after 4 to 6 weeks, and he was very sad to stop this activity. Again, an example of improving pinch grip and grasp function, and here you see the circle how we started. We had this trapped under the index finger thumb, and we tried to give him a proper pinch, that the thumb muscle pinches at the lateral aspect of the index finger. And he was very motivated. He did twice a day, 25 minutes stimulation, only by doing this function. And 4 weeks later, he could get his pinch grasp. The only challenge, we did it in a group setting, was the electrode positioning, because by so small muscles, it's very critical to place electrodes precisely. So here in this picture, you see a person where we did stimulation on the spine of the thoracical part, and we put the electrode on, and those 2 pictures illustrate how it looks like if stimulation is on and off. It's same time, the patient was stimulating on both sides the triceps. Even with a lower motor neuron lesion, motor learning might be possible. And in this case, it's a chronic patient after 17 years of lower motor neuron lesion. And his target was to manipulating objects like credit cards, coins or parking tickets. And we performed a stimulation over 12 weeks. And we had the typical stimulation protocol as used for lower motor neuron lesions, a warm-up phase for 3 minutes and a treatment phase for 30 minutes. And we all were, as this training period, really grip a card and use his hand very functional. Here on the left side you see the training, how it was performed. And on the other side in the video you see how he could use in daily living his arm. And it was quite impressive also for him that after 17 years he was able to drive a car and use his hand on a wheel without additional devices that help to grip on the wheel in the car. So strengthening with motor learning, here you see an example of the extensor within lower motor neuron lesion. You see an example for the ECU, and we combine it with a tape or with elastic band to strengthen the muscle, and you see it quite fine. So this would be the example here in the hand. And the last two examples, the first interosseous and the ECU, where we stimulated in those patients. We also performed a study and had a look about results after 12 weeks of stimulating chronic denervated people. And you see here our aim was to investigate the effect of those long pulse stimulation in these two denervated hand muscles. And we wanted to see if we can restore muscle structure or maintain muscle structure. And yes, we could, and that was quite successful, and we could it in both significantly in muscle thickness and also in the pennation angle in both muscles. And the pennation angle is a factor you can use for determining or showing muscle structure. Now I want to shortly focus on sensory stimulation. That means that stimulation can be effective for voluntary movement even if no visible contraction, that means a contraction by applying stimulation over threshold, is used. And you see it here in this person. He was asked to draw a bow on a sheet of paper, and we did it before stimulation, and we did it with stimulation and after stimulation. And you can see in the colors how he improved over time, also as a short-term effect after stimulation, if you look to the green line. And you see how this bow could increase the size. So that's quite a good method to work on fine motor skills. Coming to the next slide, there's an example of spinal cord stimulation. That was an incomplete tetraplegic person, Asia D, obviously, and he was a squash player before and wanted to play after his spinal cord injury, also squash, and he did it after his injury. And he is also in a chronic stage after 4 years of injury, and he came to the Swiss Paraplegic Center to try if cervical spinal cord stimulation somehow would improve his grip strength and his fine motor skills. And it was interestingly that we saw an immediate effect after applying stimulation by playing squash. And he had this issue by playing squash. The racket was turning around in his hand, and he had sometimes not the capacity to give a really good smash back with the ball. And after the stimulation, you could hear it immediately, the sound of the ball against the wall. And he had a stable grasp and could really hold in his hand the racket. A side effect we saw also was that his side lunges improved, and you can see it on the two slides. It was above, the one was before stimulation and the other was after stimulation. Of course, it was not a long-lasting effect, and he took a stimulator home and he's continuing stimulating because he realized that even writing by applying before electrical stimulation has better stability by holding a pen in his hand than without. And he used it on a regular basis because without stimulation he can't maintain the function. So to conclude, you see here electrical stimulation has three modalities. We can do sensory stimulation, motor stimulation, and stimulation of the spinal cord. All those three methods have the same idea, and the idea is to retrain the nervous system and to stimulate a form of learning that reconstructs or restructures the residual nervous system and promotes new neural connectivity. And there I want to conclude, and I thank you for your attention.